Thank you for inviting me, and it's good to be back in Sydney and sort of have fond memories of the 2 years that worked in Fairfield, and it's sort of a period of time when after finishing GP training, that sort of came and worked in the unit in Fairfield, and I think sort of as a starting point to step into sort of a clinical academic world. So it's sort of great to come back sort of 16, 17 years later. So today, sort of going to sort of split sort of my talk into sort of first looking at CKD, chronic kidney disease, and sort of making kidney health meaningful, and then sort of later coming on to sort of acute kidney injury as a lens into supporting better systems of care and sort of whether that's possible. As sort of work is undertaken through the National Institute of Health Research, which is the research arm of the NHS, and just to acknowledge that. And also the work that I've been doing and involved in is through an NHS England program called Think Kidneys, and there's a website that sort of you may want to refer to at some point if you want some more information about that. And also work that we're currently doing is through the Royal College of General Practitioners. And sort of today, sort of putting things in context, that there's a knowledge gap and understanding that around kidney health and making kidney health meaningful. I'm going to talk about sort of diagnosis and management of chronic kidney disease in the UK and where self-management support fits and doesn't fit into the framework of care for people with long-term conditions. And then come on to sort of acute kidney injury. So over put it in the context of the sort of there are new classification systems over the last couple of decades. The introduction of chronic kidney disease as a new international classification system, and then followed by acute kidney injury. And these chronic kidney disease came in 2002, and acute kidney injury in 2012. And introduction of classification systems aren't necessarily uncontested. And actually in primary care has often historically had a central role in shaping their implementation. And I sort of look at sort of work of David Armstrong, who's had a paper in Social Science and Medicine, and I sort of hold sort of this paper in mind quite a lot when I'm thinking about chronic kidney disease and acute kidney injury as new classification systems historically into the world of healthcare. And there's a quote in that, it's the classification systems both structure and constrain the world they describe. They act as the lens of perception, as the mediator of experience, as a conceptual framework through which medical reality is stabilized and then maintained. And this poses sort of challenges in a world of concerns about too much medicine. How do we navigate this challenge of making most use? And so where's the utility of these new diagnoses and classification systems to improve quality and safety, improve health outcomes, at the same time as sort of ensuring that we minimize burden for both patients, carers, and workload burden for professionals. So it's sort of holding that, sort of navigating that challenge. And I would argue that's primary care and primary care research as a central role in shaping that, sort of navigating that. So to bring on to sort of, I mean, chronic kidney disease and acute kidney injury comes from a point when there's a historically low awareness of what the kidneys do. And this is sort of an example of that. I think Kidneys Programme did a survey in 2014 through an Ipsos Mori poll. And sort of what they showed that people don't have a comprehensive understanding of what the kidneys do, how to keep them healthy, and what acute kidney injury is. That only about half the population know that the kidneys make urine, and that only about just over 10% of the population know that the kidneys have any role in processing medicines. So from this starting point, sort of, that I think Kidneys have sort of created sort of a patient and public awareness campaign, and for professionals to how do we make kidneys more meaningful rather than getting caught in sort of chronic kidney disease and sort of, okay, thank you. So they would put out a public campaign and they show it's a highly vascular organ, and that's sort of it's important for removing waste from products in your blood. It regulates salt and water in the body. It's important for maintaining our fluid, our fluid balance. They produce a hormone that manages our blood pressure. They create erythropoietin, a hormone that helps production of red blood cells that prevents us becoming anemic. They activate vitamin D, so they're really important in maintaining bone health. and they clean the body of drugs. So they're important in sort of the role of processing medicines. And they end on a positive note around kidneys, and this reframing that kidneys and kidney health is really important. It's vital. But let's have a look at sort of moving on to sort of kidneys in the context of the UK and its implementation over the last 20 years. So just focus on sort of a brief history of that. To do that, I'm just going to start giving you a sense of where I've been for the last 16, 17 years, having left Sydney, being largely based in Manchester and in Leeds and in the north of England. And these few images of Greater Manchester. And a couple of things to note. One, the architecture is largely from the 19th century. And there's probably more blue sky in these images than sort of Manchester is renowned for. So without putting you off, sort of, you know, it is known for its rain. This is a map of the wealth of the world in 1900, and Manchester is sort of in that pink area, and that's largely based on sort of, it's the Industrial Revolution, and sort of the wealth of the world then got distributed to North America, where the rest of Western Europe, Asia, and the rest of the world. And Manchester, really, where is it? It was at the heart of the Industrial Revolution. With the mechanization of sort of the textile industry, it became sort of identified as the world's first industrialized city. And in that, it was sort of seen as radical and repressive. Manchester is both seen as innovative in terms of sort of development and industry, but also repressive. There were social inequalities that came to light in this context. And this led in 1819, 200 years ago, sort of August next year, sort of Manchester was at the heart of political reform. And people began to say that actually things weren't right. And what happened was there's a peaceful protest in central Manchester in 1819, and about 80,000 people gathered in the centre of Manchester. Well, unfortunately, the cavalry charged, and sort of about, I think 600 people were injured and 15 people were killed. And this is important. This led to sort of further political reform. So though that happened, it was the start of further political reform that came through what was happening in Manchester and the Industrial Revolution. It led to the public formation of the Guardian newspaper. And if you're interested to know more, there was a film out in this last year about Peterloo, and it's called The Massacre of Peterloo. Not unrelated, this is Sydney in 1819, and this is a painting of Sydney from that time. And what we see is sort of, there was transportation from the UK, and that transportation was in the context of social inequalities and poverty, and largely people being transported for minor crimes, but in the context of poverty happening in Manchester and cities alike. Well, social inequalities still exist. This is sort of Manchester, this is the UK in the 21st century, and the pockets of deprivation largely in Scotland and the north of England, and affluence tends to be in the south. So there is a north-south divide, and that needs to be taken into context when we're planning services. But sort of, we move on to sort of the birth of the NHS. It's in this context that the NHS emerged. And although it's sort of how it's changed over the last 70 years, the principles of universality, equity and quality remain fiercely defended. And that is everyone's eligible for care. It's free at the point of delivery. Care is based on clinical need, not ability to pay. And services are financed through central taxation. And it's maybe not sort of Nye Bevan, who was the Secretary of State for Health at that time. I think there's a decision to open sort of, or symbolically open the NHS in July 48 in Manchester. General practice in the UK, so GPs independent contractors, they remain so. They're official gatekeepers. Probably the last 20 years, it's been computerized. Range of practice sizes, and practice teams are developing, and funding for that is evolving as well. GPs, nurses, healthcare assistants, practice pharmacists, prescribing link workers. And there's a new contract that's come out in the last, just this month actually, that formally funds some of this new workforce into primary care and general practice. Capitation based, so actually sort of GPs largely get funded according to the number of patients that register the practice. And then there are payments for quality indicators for long-term conditions. There's an increasing focus on frailty, and I said there's a new contract, which I'll come on to later on in the second session and touch on that. But that focuses the shift to the development of integrated care systems. This shift is sort of in the context globally of a shift to long-term condition management. And then 20 years ago, there was a white paper that framed quality of how to deliver high quality care in the NHS. And that involved the setting of standards, the delivering of standards, and the monitoring of standards. There's the introduction of the National Institute of Clinical Excellence that led to guideline publication to drive improvements in care. In general practice, there was the introduction of the Quality and Outcomes Framework, which you might be familiar with, which was the incentivization of delivery care for people with a range of long-term conditions. And then there was a monitoring of standards through the Care Quality Commission. So it's in this context that chronic kidney disease is an exemplar. Guidelines came out for chronic kidney disease in 2008. And these are on the back of the introduction of the international classification system, which happened globally in 2002. They've been revised, and they're based on changes in people's kidney function and evidence of kidney damage through leaking protein from the kidneys. Chronic kidney disease affects about 6% of the population. It's very much in the context of people living with comorbidities. It's seen as an independent risk factor for cardiovascular disease. And the guidelines very much focus on targeting and improving vascular outcomes. It's very much on identifying and targeting and ensuring tight blood pressure control and being on the appropriate medicines. It was delivered through the Quality and Outcomes Framework from 2006. So GPs would get paid for delivering on quality indicators for a range of long-term conditions, and CKD was in this context. GPs will get funded for developing a register of patients who have CKD. They will get paid for the percentage of people on that register who'd had a urinary test in the past 12 months. And then they'd get paid again for the proportion on the register who had had a blood pressure controlled according to the guidelines, and also those that are on an ACE inhibitor medicine to help people who've got leaky kidneys and leaking protein. This is an example of what the QOF outcomes are, and each quality indicator was assigned points, and these points were equivalent to financial remuneration. So these points meant prizes, and it was a way of funding general practice over the last 15 years. Again, just to reiterate, it was in the context of improving vascular outcomes. There was a national audit, however, and I'll just touch on that, that showed that there was actually a gap. Those about 5–6% of the population have CKD. About 3/4 of people have been coded, but people weren't the various guideline recommendations of having urinary testing was only happening about 30% of the people who had had hypertension and chronic kidney disease. And again, this varied according to age. So the people if you were 65 and over, it's more like 50 to 55% were having their blood pressure controlled, and higher in the younger age groups. But in 2015, these incentives, even though there was evidence that it isn't, these people weren't achieving these quality indicators, it was removed. And it's a bit hard. I tried to look around why that was the case, but if you're going to look at the British Medical Association, I think it's very much in the context of primary care workload, and there's papers out in the Lancet about primary care in the UK reaching saturation point. There's only so much people can do. And CKD was in this context. CKD was given up for then a shift to look at how do we support care for people with dementia. So these competing demands that are going on in UK general practice. It's also in the context of too much medicine. The articles in the BMJ, and particularly with a focus on chronic kidney disease, that it was the concerns about overdiagnosis. This was just unnecessary disease labeling, and it was creating, the concerns that it was just creating anxiety in the patient population. So why bother talking about CKD with the elderly? And it's touch on, we did some qualitative work through our group, and Anne Rogers, who you might have met, was here, and I think has been over to Australia a few times. But we did some work, and we used the lens of normalization process theory to look at the implementation of classification systems and sort of, you know, looking at the work that's going on in practice. So I did some qualitative interviews as part of that team, and sort of, if you, one GP says, if you've got CKD and you're young and you've got proteinuria, definitely it's an important thing to hammer in. But yet 80, 90-year-olds, I wouldn't suggest we're probably discussing it if they've got mild CKD. So early stage CKD, why talk about it? And sort of there's this thing about partial disclosure, and sort of there's nothing really to worry about, and what that really means, and how sort of the meaningfulness of it gets lost somewhere. As a nurse that was interviewed said, I try and reassure them at the beginning there isn't actually anything to worry about because they've got another new condition. Just to let them know, I feel they should know they're on a register, and tell them not to worry. If there's anything to worry about, we'll let them know. And I guess it's sort of question, how do you bring the kidneys into conversation and frame it within the clinical encounter and beyond? And this sort of fits, so the quality and outcomes framework is on its way. In Scotland, they've got rid of the quality and outcomes framework. In England, it's been downsized to some extent, and it's shifted to actually incentivizing quality improvement, which I'll touch on later on. But Martin Rowland and Bruce Guthrie did an article in BMJ, and although the QOF has improved, so, you know, evidence of improvement for incentivized conditions, it might have reduced the rising in emergency admissions. There's also the concern that that the needs of increasing population of older people with multiple complex problems were poorly served by indicators that focus on single diseases. There's this notion of it's a single disease framework, and the delivery mechanism was potentially isn't making things straightforward. Touching on things, and Ben and I had a conversation on Friday, but sort of self-management support in the 2000s came up as a policy framework, and there's a lot around it in the 2000s, the time I was doing PhD, in the context of sort of the NHS, about providing meaningful information, support in monitoring condition, adjusting medicines, support lifestyle change, and then linking to access to community services. But so we did some work around video recording GP consultations, and then sort of taking those to stimulate accounts with nurses, patients, and practice nurses. And in analysis of those consultations, it was difficult for self-management dialogue in this context to become a legitimate topic. The QOF templates, and particularly nurse consultation, were reinforcing a checklist approach. So it didn't open up necessarily a scope for expansion on people's needs. And sort of, but the other thing is that sort of when people then got into sort of a trouble and repair interaction, where it would become a problematic thing to talk about, and there wasn't space. And what you'd see is the health professionals might actually turn to the quality and outcomes computer template as a way of sort of moving away from sort of the issues and the difficulty in the relationship that came up in talking about lifestyle change. And the key point was that people were needing to maintain the relationship. How do you maintain the relationship in the consultation and also talk about supporting self-management? So there were difficulties. So briefly, so before I hand over, we then used that, and working with Anne Rogers and the team, we we looked at, I'll just move on. Basically, CKD is common, it's in the context of morbidity. Okay, thank you. And it's also in the context of people, CKD is more common, it's more common in people in areas of socioeconomic deprivation, and also there's limited health literacy, and that's common in people who have chronic kidney disease. So there are issues to be thought about. We did a trial, and we sort of designed intervention thinking about Anne Rogers' framework of self-management support and linking it about social networks, but recognizing there's a need to understand what kidneys do. So we designed an intervention that took into account and built on the everyday routine consultations, where we developed a kidney information guidebook, and that built on the work of drawing on patient experiential knowledge of illness and care, and also drew on sort of professional knowledge of the need to why focus on the kidneys. We also developed sort of it was called a PLANS, patient-led assessment for network support, how people can think about what their priorities in life and how to then sort of shape, how do we address things and take things forward. And that was backed up with telephone support from a lay health worker to help people, signpost people, the beginnings of sort of care navigation and sort of, I guess, context maybe social prescribing, but care navigating, signposting people to relevant service, be that to support lifestyle change, but maybe actually to address issues of loneliness and social isolation. We did a trial, so it was a patient-level randomization across Greater Manchester, and 24 practices took part, and we had a 6-month follow-up period. So it was a starting point around this. The results that we showed, there was maintenance of blood pressure control. There were modest but significant improvements in quality of life and self-care activity. We used, and I touched on with this Ben earlier, we used a HiQ score to sort of measure self-management, and maybe there are other scales to be using, and whether patient activation is something to consider. But the other thing is what we also showed, there was no there was no evidence that it had a detrimental effect on patient anxiety in talking about kidneys in this, framing it this way. I think that's in a way, I'd take that as a key point, that actually you can talk about kidneys, it's just how you frame it and how to make it meaningful. So I'll end there, but these were just a few questions I was thinking about. Is self-managed support, has it been rhetoric rather than reality? Are the mechanisms for, the mechanisms for delivering chronic disease management, do they really take into account self-management support? Is there a need to reframe the conversation, the consultation, the delivery of care? What's the role of the workforce looking ahead? What are the role of linked workers, care navigators? What's the role of theory in designing interventions and designing services, and how do we take that into account? I've been drawn over the last 10 years or so into normalization process theory, standing everyday work. And then what's the role of maybe prompts, as a way of supporting improvements in care and conversations, and also measuring and getting some sense of impacts that are improving, people, engagement in activities and outcomes. So I'll end there, but maybe we can come to some discussions later. Thank you.
Before we hand over, are there any quick questions of clarification? No, you were very clear. Oh, is there one? Oh, I'm sorry.
It might be a question for later, but I'm just curious, is there a potential that this approach can switch it to patient saturations and too many conditions that from a patient perspective, rather than the GPs saturating with various conditions? What about the patients who've got multiple chronic conditions?
I think that's for later, or do you want to repeat it and answer it quickly?
I think it's for consideration for all, really, about how we're just creating burden, and chronic kidney disease in the context of, really people with multiple conditions, and how we reframe it, it's rather. And I guess maybe it comes on to later where multimorbidity sits, both in the research world and in clinical practice, because it's the term that's shifting away, that we need to address multimorbidity. But when I'm in clinical practice and the staff and chatting to a community matron I work with and the GPs, and no one uses the term multimorbidity. So I guess it's how all these things, how we frame it, both can structure and constrain, and what's the most useful way